But with that, we'll go ahead and get started with today's seminar. And I am honored to introduce our distinguished speaker today, Dr. Bryan Sisk. Dr. Sisk is an assistant professor in the Division of Pediatric Hematology and Oncology at Washington University School of Medicine. And he is also the Director of Research for the Bioethics Research Center, where he plays a pivotal role in advancing bioethics research. Dr. Sisk co-directs both the Vascular Anomalies Center and the HHT Center of Excellence at Washington University. And his research is, I would say, is groundbreaking and delves into the social and ethical complexities surrounding the care of vascular anomalies and the engagement of technology in clinical settings. He has an impressive record of productivity with over 100 peer-reviewed manuscripts and has really established himself as a leader in pediatric communication. And please join me in welcoming Dr. Bryan Sisk.
Thanks so much, Mike. It's really, really kind. I'm excited to be here, and this will be a little change of pace from our normal topics on this seminar. And I'm hoping that we learn some interesting things together today. So I do have a couple disclosures. I consult for some pharmaceutical companies, but none of it relevant to today's talk. What we're going to go over today, I'll spend the first part of the talk really just laying out that there are challenges to communication and healthcare access, and what we've learned from some rigorous study in vascular anomalies. And then we'll use the second part of the talk to go over 3 different technological solutions we're experimenting with to see if we can overcome some of these barriers and burdens. So to start this whole story, I need to go back about 5 years ago when I first became interested clinically and in my research curriculum on vascular anomalies. So before that, I had focused almost exclusively on communication in pediatric cancer. And then I started seeing patients with vascular anomalies in clinic and was just struck by how many challenges I was hearing from family after family. And I thought, I've got this whole research skill set that I've been focusing on cancer. Why don't I just apply it to vascular anomalies? Anytime I start a new research question, my first step is to do a systematic review or a detailed search to figure out, what's out there in the literature, where can I fill in the holes? And so to give a little bit of context, the same year, I had done a scoping review in pediatric cancer, and the search for this review included only communication studies, only pediatric cancer, only in English, only in the US, and only for 3 years, and we found 98 studies. I did the same search for vascular anomalies, except I expanded it to any publications ever for any vascular anomaly, and looking at communication, healthcare access, any of those issues, and we found 4 studies ever. And 3 of them were authored by this researcher named Anna Kerr. And so I reached out and made a partnership with Anna, and now we've been collaborating for the last 5 years. And rather than a scoping review, we said, let's write a commentary saying, hey, there's huge unmet needs and really unasked questions that we need to dig into because we know there's problems when we see patients in clinic. So that led to our first study, which is really characterizing what are the challenges. For anybody that's on the call that's written grants before, the first part of any grant is going to be your background and your significance. And in that, you have to be able to show this is an important and really significant and really burdensome challenge, and we are the right people to overcome this challenge. The problem here is I didn't have any literature to point to. So it's really hard to get a grant to fix a problem that you haven't shown exists. So I have immense gratitude to patient advocacy groups listed on the side here who took me under their wing, who helped me in part with funding this project, in part with recruiting patients and participants, in part with understanding the experiences of families. And so this first study had 3 aims, 2 of which we're going to talk about today. The first aim was interviews, where we really wanted to characterize parents and caregivers and then adult patients' perspectives on their experiences with communication, with accessing the healthcare that they need, and with simply what the burden was of having the disease that they had. The second aim was to get at similar questions, but with validated outcome measures so that we could start to quantify some of these issues, really to lay the foundation that we could start building a research path off of. And I'll go over a couple of the findings that we had from this study. So one of the big advancements we had developed in pediatric cancer communication is our team developed what's called a functional model of communication in pediatrics. And the functional model means that if you're trying to communicate well, we define communicating well as fulfilling these 8 unique interconnected functions of communication, which includes on the screen, making decisions, exchanging information, responding to emotions, providing validation, supporting hope. And all of these occurred within the context of that really strong clinical relationship the patient and the family had with their cancer team. And that relationship influenced every one of these different functions. If you had a bad relationship, you were less likely to trust their information. You would have more difficulty making decisions. You would feel like your emotions weren't being responded to, and then vice versa. The stronger relationship fed into and supported all of those functions. So that was the background, and we wanted to see how this model adapted to vascular anomalies. And there are some interesting findings. First, the importance of managing uncertainty and the prevalence of uncertainty for these patients with vascular anomalies was way higher. And we'll talk on the next slide about uncertainty and why that's so hard for these families. The other things that were worrisome is there was very little discussion of supporting hope, which I worry is because people didn't have a lot of hope. And which is understandable because some of the patients we saw in clinic or some of the patients we were interviewing might be in their 50s or 60s, and they told us stories about how it took them 40 years and 10 wrong diagnoses to finally get the right diagnosis. Some with stories about how doctors told them to stop coming to see them anymore because they couldn't fix them. So, and we only have known about the genetic changes driving these for the last 15 years. We've only had any treatment for like the last 10 to 15 years that's medical. And then we've had our first FDA approved treatment in the last 2 to 3 years that only applies to some of these. So even though we're in a very hopeful time now, I think a lot of families were coming in with low amounts of hope. The other worrisome thing is participants were really downgrading the importance of relationships. And the way that I interpret this is that there was such a need and such a desire by these families to find expert care at all, that they were willing to overlook any relationship issues. If there's only, a jerk or a rude doctor who can help my child, I'll take the jerk or the rude doctor. And it's almost like a hierarchy of needs of relationship would be great, but I need to find somebody first. And as we'll go on, we'll explore that a little bit more. So really this model in vascular anomalies, the background was really uncertainty. And when we think about uncertainty, these are just a couple snippets of the types of uncertainties families told us about. And some of these are adult patients, some of these are caregivers. But some of the questions: can I have kids? Should I have kids? Thinking about your child, are they going to be bullied because they have a visible difference when they get into school? When you're thinking about interventions, there's limited evidence. What's actually the best treatment? What are the long-term side effects? We have a drug that we only have 5 years of experience. How do we know what's going to happen to my child in 30 years after taking that medicine? For now, there's interest in this community by scientists, but is that going to persist? If there's one bad clinical trial, or all the clinical trialists, or all of the pharmaceutical companies going to back out? Do I actually have the disease that I'm told I have? There's a French study that found that about half of patients that made it to their multidisciplinary center had the wrong diagnosis. And then just more generally, what's going to happen in the future to my disease? And then the other important point when I go through this is thinking about, as clinicians, what our role is in managing uncertainty. And this really stood out to me when one participant said, I feel like sometimes doctors are just recommending treatments because they don't know what else to do. And so I think it's also important that we recognize, how are we making choices? Are we tolerating and managing our own uncertainty by making recommendations for doing something, even if we don't think it's going to fix or help the problem? So the next question was, what are the actual challenges families are facing? And what we identified through this qualitative study was really 4 pillars: the disease process, logistical, financial, psychological and emotional, and then social. And we'll go through those each in a bit more detail. So, prior to our work, there was some evidence out there of using patient-reported outcome measures and determining that patients with complex vascular anomalies have worse physical pain than the general population, and that they can have lower physical functioning and role limitations and debility. So not striking, but at least there was some preliminary evidence of those physiological challenges. We added a little bit more characterization to that, and here's just some of the challenges within the disease process. So obviously pain, weakness, limitations, side effects of the treatment. Another huge one that wasn't talked about a whole lot is sexual and reproductive health. Both of the fertility, risks of pregnancy, but also if you have a visible malformation near your genitals. Some people were less likely to want to engage in relationships with or find partners. There are certain disorders that had cognitive deficits. So it's important to recognize the vast array of physical burdens and what that means when you're developing clinical trials and you're trying to improve the quality of life of patients. But this is really the easy one. I think as scientists, as clinicians, that's what we go to, is how is this physically manifesting in your body? The other aspects of their experience are also really important. And this is based in the US, but families with vascular anomalies had multiple financial and logistical challenges. So as we'll talk in a few slides, these centers are few and far between where we pull together multidisciplinary teams of experts. So often people have to drive 1, 2, 3, 4 hours to get to the right specialists. Sometimes insurance won't let you get into that health system, or you have to fight with them for a long time, or you have to fight with them to get the medicine you need. When you want to travel, it costs gas money. You might need a hotel. You might need to take off work, or you can't. You might need to miss school, or you can't. And then also some of these patients have one side of their body is different than the other, and trying to find shoes that fit. The major challenges of getting compression garments. Insurance will cover a drug that costs $30,000+ a month, but they won't often cover a $200 compression garment, which might have just as much effect on a patient's life. These are all real challenges that families encounter. There's also psychological and emotional distress. There's higher levels of anxiety, depression, guilt, shame, feeling traumatized. And again, with this last kind of emotional trauma point, it's also important for us, again, as clinicians, to think about what role do we play in perpetuating some of these traumas. And I bring up this excerpt, which was a participant reflecting back on when she was a child going to her multidisciplinary clinic visits. She said, I was 5 years old. I had one side that was bigger than the other. And to me, it felt like there was a parade of doctors that came in and looked at my leg and not at my eyes. And they stripped me, and they kept saying, that's so interesting. And then they took pictures and they sent me on my way. And so each of those things are important. We need to educate doctors about this and trainees. We need to have multiple doctors with multidisciplinary care. We need photographic evidence so we can monitor over time. A lot of it is just the way that we're framing it. And this patient summarized it as, it's like they're trying to compliment me as that's so interesting, but I'm not interesting because of my leg. I'm interesting because of who I am. And so sometimes it's making sure we acknowledge the humanity of that person. Sometimes it is asking permission and explaining why we're taking pictures, where it's going, and making sure that we don't objectify them as a disease rather than a human. In some of our quantitative studies, we also found lower mental and physical health than the general population in these patients. And we found that patients who reported higher education, but also patients who reported getting better information about their vascular anomalies, reported that they had better mental and physical health. Now, this is clearly not necessarily causal. It doesn't mean if you give better information, these will improve, but it opens that possibility that maybe information and the quality of our communication might have a role. And we'll keep coming back to that point. The other aspect is the social well-being of patients. So there are a lot of concerns of exclusion, bullying, insecurity, their perceptions of stigma. And this was from Dr. Kerr's study before we started collaborating, but it's a really pertinent point. This was a mom who had a 3 or 4 month old baby who had a very visible vascular anomaly on her face. And she was walking through a grocery store, and a complete stranger came up and said to her, what did you do to your child? Because she thought it was bruising on the face. And unfortunately, a lot of times it's complete strangers that come up and do these things. But the mom had said in that paper, it was the most horrible feeling that somebody thought I could have been the cause of her birthmark, because I'd spent the last 3 months trying to convince myself that it wasn't my fault. And so I think this is important to recognize that parents are carrying a lot of experiences and a lot of burdens into our visits that we don't have insights into, and we need to kind of have humility about what we do and don't know about their path. When we look at it quantitatively, we found that higher reports of stigma, as you can expect, are related to worse mental health and worse physical health. It's hard to change society to stop stigma, but we can at least acknowledge it and recognize the impact of it on families. But the other big challenge that we started to unearth here is how much families struggle to find specialists who have knowledge about these disorders. And here's just 3 quotes from parents that summarize a couple of the challenges. So we have lots and lots of problems finding doctors in our area that are basically even willing to work with her. And this is especially challenging in rural areas. We have to go across the country practically to get the care that we want with doctors who really, really know what this is. And then once you find those doctors, even if you can travel, getting that first time appointment can be months out. Some places are 6 to 9 months before you can get your first visit. So we did first a qualitative exploration of what are the factors that influence whether these families can access and then maintain expert care. And what we found is there were 6 different factors, and I'm not going to go through them all, but they're listed up here, but 6 different factors that influence their ability to access care. And a couple important points. Once again, the quality of information was the ether in which all of these factors function. So better information about scientific progress, about the healthcare system and insurance requirements, better information and better communication seemed to improve the positive effect of each of these characteristics. But there's 2 other points I really want to make on this page. One is luck and privilege. In general, if you have more money, it's a little bit easier to get the medical care that you need. But beyond that, there are many wealthy patients that still aren't accessing care. And so much of the ability to find the right doctor depended on if you were lucky. And the best example I can give you of this is one of our studies. We had 2 families in New York City, pretty much, probably a few blocks away from each other where they lived. The first interview, the family said, it's amazing. I live in New York City. It's the center of the world. My child was sick. We had our first appointment. We found this amazing team. We have all the care that we need. It's really great to be here. And it's amazing that we can just have all the resources we need at hand. The second family, a few blocks away, said, it's really unbelievable. We live in the center of the world in New York City, and we can't find anybody with this expertise who can help my child. And what you realize is that the factor of whether or not they got their care probably depended on which direction they went down the street to go to the hospital. Did they go to hospital A or hospital B? Or even within that hospital, did they get referred to rheumatology or orthopedics or dermatology or hemonc? Even within hospitals, there's sometimes limited awareness that these multidisciplinary teams exist. So that's a huge challenge that we have to try to overcome, because you can't just work harder to be lucky. We have to try to change luck for these families. And then the last point is the healthcare system, which has lots and lots of challenges that we'll dig into in the next couple slides. And so the nice thing when you're a researcher is when there's a really important question that's just sitting there that nobody else has answered. And so the first low-hanging fruit question, that's a low-hanging fruit. The first low-hanging fruit question was, where can families go to get vascular anomalies care, and what resources are available? And so I collaborated with Dr. Cohen Cutler at CHOP, where we mapped out of all children's hospitals, where are the ones that have multidisciplinary care, and which states and which regions are really short in that care. And then we also characterize what types of resources and all that. I'm just going to go over where these places are. So this is pinpoints of all of the children's hospitals across the country. This is all the places that report that they have multidisciplinary centers or multidisciplinary programs. The caveat here is not all of them have the same resources, and not all of them would necessarily be what we consider multidisciplinary programs. Even considering that, there's 14 states that don't have multidisciplinary centers. I apologize, Hawaii got deleted. They do have a center, and it's lovely to visit. So look at the gray spots. There's huge swaths. If you're on the East Coast, if you're in, Western California, you're fine. But if you're in kind of the Northwest, Midwest, you're going to struggle. The other thing that's a struggle is if you happen to be an adult. So this was not my work. This was Ianella and Fran and some advocates and colleagues who did a survey study to understand where adult patients were accessing care. And 60% of the adults still saw pediatric hematology oncology doctors. And of those, half of them said they didn't have an adult physician to transfer to. The 40% that aged out and could no longer be seen at the children's hospital, a third of them just stopped looking for specialist care. And they would either rely on a primary care doctor, or they'd rely on urgent care or emergency department, but didn't have anybody with an invested interest and expertise. When we looked at some of our quantitative data, we had an outcome measure that was a self-reported ability to navigate the healthcare system. And this got at all the different aspects of knowing what you deserve, what you need, and how to get access to it. And what we found is that patients who reported a better ability to navigate the healthcare system, they also, again, reported better information about their vascular anomalies that they got from their teams. And they also reported better knowledge of their primary care doctors about these disorders. So that's important. To me, the most important point on this slide, though, is we had another measure that looked at patient self-advocacy. And this was a measure of how strongly do you advocate? How much are you willing to be the squeaky wheel to push and get the care that you need? And we found it was literally no correlation at all. There is no relationship at all between how strongly you advocate on average with whether you get the healthcare you need. And to me, that really reinforces all of our qualitative data of we can't expect patients to just work harder to get the care they need. We have to figure out how do we modify or create workthroughs or workarounds to get them that care. And so this is the part of the talk that's it's depressing up to this point, because I've just been pointing out everything is bad, everything's terrible. So, and it kind of is to an extent, if you need care for a vascular anomaly or a complex lymphatic anomaly, you're going to struggle if you don't have experts nearby, if you're not able to travel to the center that has the right clinicians, if you're not lucky, if you made the bad choice to become an adult. Like all of those things are going to make it harder for you to get the care that you need. But there's green shoots. Maybe we have evidence that we can leverage this relationship with primary care doctors. Maybe we have evidence if we can improve communication and the provision of high quality information and make patients more knowledgeable about their disease, they can better advocate as well. And so these are the big problems that we're trying to address right now in our lab and in our team. The first is, how do we fix poor communication or lack of information? And the second is, how do we overcome or address these access barriers? And I'm going to talk through 3 different technologies to address these 2 problems that we're experimenting with. The first, when we think about communication, we're going to talk about a communication tool that we've built within a medical record system. Excuse me. The second, we're going to talk about large language models. And these are all ongoing studies, but I think it's worth starting to share what we're learning already. So Care Companion, Epic is one of the major medical record systems across the country in the US. About 70+% of large pediatric hospitals are using Epic now. What's exciting is that within every single instance of Epic at every center, there's an infrastructure that people can use called the Care Companion infrastructure. Within this Care Companion, you can create kind of an educational path or a module where once you sign up a patient for it through their electronic portal, they can get information about medication tracking, or you can track their vital signs or have them enter data. You can provide educational content, which could include text or video or images. You can create any type of a survey that you want for periodic check-ins. So it's limited in structure, but there's a lot of things that you can do within the structure. The challenge is that almost nobody is using it, and nobody's using it in the way we were interested in trying to improve communication. So we wanted to learn, how can we leverage this Care Companion infrastructure to address the communication and information issues? And when you think about human-centered design, there's really 3 phases of it. First is a needs assessment to say, what do we need to actually fix? The second is, how do we design and develop this? And then the third is, how do we test it and evaluate this? So the phase 1 really is all of the research we were talking about in the first half of this talk. And now I'm going to talk about really the phase 2, because phase 3, we're just finishing up our final patients in the pilot study. So we designed and developed this through a process called participatory design. Participatory design is a form of user-centered design. And the key principle of participatory design is if we're building a tool, we need to engage the people that will use that tool to make sure it's useful. And so it's an iterative back and forth where you have these workshops where you actually design components of the tool, build it, get feedback, build it, get feedback, build it. And then by the end, you can take it into practice and either implement it or test it in a trial. So we wanted to engage both caregivers and adult patients because these are rare and patients are affected across the lifespan. And we also wanted to incorporate specialist physicians who take care of these patients. Once we did that, a final step before you take it into, before you decide you have your final design is called usability testing. And this is where you actually, you get on a call with somebody like through Zoom like this, and you give them control and let them click buttons and let them use it. And they can tell you in real time, this works really well. Wait, I don't know how to do this. And you actually get to see them use it and figure out what final tweaks do we need to make so this is a usable and helpful tool. Then you've got your final design and you can take that into whatever assessment you want. When we went through our participatory design workshops, where there was somewhere between 4 and 7 participants in each one, and they kind of talked iteratively between each other and came up with concrete plans. There's really 2 key lessons I want to highlight. The first is we were asking them about how should we do check-ins? How should we do surveys? How should we get feedback from you to the clinicians about how you're doing? And what was important is that a lot of our participants expressed frustration with standard patient-reported outcome measures when they're used in clinical practice. And there are a couple reasons they expressed this frustration. One is some of them, like if you think about a 10-point scale, they really struggled to know or remember what that number means to them and how to be consistent in how they apply it. Am I a 5 or am I a 7? The other is they often felt like they filled out a bunch of surveys and never got feedback or responses from clinicians. And so some of them just started clicking random numbers. So what this taught us is that we really need to make sure in this type of a tool that we're creating these check-in surveys that are actionable and that are easy to answer. And so with their feedback, we designed this check-in survey that you don't have to see all the specifics on the right, but the outcomes are really simple. So how's your pain been lately? Rather than giving them in the week, in the month, it's like they can decide what lately means and whether that's meaningful. And it's either it's the same as usual, it's worse, or it's better. Really, that's what mattered to them, because if it's the same or it's better, they didn't really need the doctors to respond to that. But if it's worse, they really wanted their clinical team to reach out. And so it was the same thing with physical health, with emotional well-being, whether they have had unplanned emergency visits or hospitalizations, whether they're having any access issues with getting the care they need or troubles with medicines. And then we also gave free text ability to enter in whatever information they wanted. And then within the portal, the nice thing about being structured in the portal is you can create trigger alerts where if you decide which responses are indicating there's a problem and need a response, and then that creates an alert that goes to whoever you designate. So we created trigger alerts of anything that was free text or anything that indicated things were bad or worse would create a trigger alert, and it went to our nursing pool that handles every phone call and every patient portal message that comes in, and they treated it just like that. It creates a new folder on the end recipient's Epic, so the nurses on the nursing pool would see a patient escalation that lights up, and then when they open it, it would have the survey and it would have their responses, and they would read through and say, oh, it said your pain's worse than usual. I'm going to reach out to the family and get a little more detail and then put them in communication with their clinical team. The second key lesson was the importance of incorporating patient stories. This was not something we were planning to do ahead of time. When we had our first participatory session, though, many of the participants shared that it's important to get the medical information, but it can be very overwhelming and it can seem like it's pointing out everything that can go wrong. And they needed some support or some vision of what a future might look like. And they recommended getting stories from patients. We were very fortunate because this was a collaboration with LGDA that they had already thought about this as well. And they had already developed these patient stories for their website. So we reached out, excuse me, we reached out to LGDA and reached out to participants who had already created these stories and got their permission to incorporate them into this tool. And then we created one additional one from an interested participant who wanted to share her story. So when we got to the final design, this is what it looked like. And there were really 3 components, and it was 27 weeks or about 6 months. The bottom in blue, these are all different educational topics. And we developed the educational topics in conjunction with the families. And then we actually built the materials and that with 4 different experts in complex lymphatic anomalies and lymphatics. Then we worked with a plain language communication specialist to make sure everything was at an understandable reading level. And then at the top in green, we had timed out these different patient stories. And then in the orange, we had the wellness check-ins. And we chose the timing, again, based on feedback from the participants. So just to give an example of what the screenshot looks like, this is an educational material where it's got text, it's got pictures, and it's got links to videos. They wanted to have the ability to have graded or staged involvement of, give me the basics, but I want to be able to click links and get more information if I want. We are in the middle of, well, near the end of a pilot study where we have 22 participants with lymphatic malformations and complex lymphatic anomalies. We have pre-post surveys, we have brief feedback surveys that we gave throughout the course, and then we're going to have post-intervention interviews. The only ones that we have completed right now, because there's still a few patients outlying, are these brief feedback surveys. But I'm just going to highlight 2 points that were made up that were really important to me when I read through them. One was a parent who said, as a new parent of a child with a lymphatic malformation, the general information would have saved us endless internet searches and a lot of anxiety. Additionally, the patient's stories likely would have made the whole experience feel less isolating. So this helped me to feel confident that incorporating those patient stories was the right approach. The second was somebody who said, a nurse reached out after I had a recent flare that I referenced in the wellness check-in. And it was really nice to know that my responses would receive feedback if necessary, because I feel like a lot of surveys, are often given, but little feedback is returned, and that's not like this. So again, that importance of responding to the effort they're putting in to tell them how they're doing. So next steps, obviously we're going to finish this study, but really the next step is thinking about scalability. One thing that we've learned as we went through this is every single instance of Epic can incorporate this. The challenge is that Epic as an organization has not decided that it's a priority to make it easy to move a care companion from one center to another. So they're easy to build, but to get this at multiple hospitals, you do have to get in the queue and get buy-in from that institution that they're going to build that up. So I think an important question is, what if we take this and make this available on the web outside of the patient portal? What do we lose and what do we gain? We get more flexibility in what types of tools we can create. We get more flexibility and scalability, because then even if you're in a hospital where you don't have portal access or you have a different company, you can still benefit from this. But there's some trade-off because you might lose some of the benefits of having direct communication with your clinical team. So that's what we're working towards as a potential next project. So the next thing to talk about is using ChatGPT and large language models to see if we can answer families' questions about complex lymphatic anomalies. So I suspect most people here have heard of ChatGPT. This is my extremely simple explanation of it. If you have a question and you go to ChatGPT and ask that question, it takes, billions or trillions of data points, and it's really good at predicting what response should come. And then it gives you an answer. And then that answer can be of good quality or bad quality. What we'll talk about is that surprisingly, ChatGPT-4 actually does a pretty good job of providing information about many disorders. When we think about using large language models like this in general, which ChatGPT is just one example, there's really a mix of benefits and potential drawbacks. So the benefits are it's always available. Some families don't want to wait on clinicians or don't want to bother clinicians with simpler questions. For our international folks on the call, it can translate, ChatGPT can translate to other languages instantaneously. It can answer follow-up questions where you ask a first question, you can ask a second and third and fourth, and it'll remember that it's in reference to that first question. And it does reasonably well for topics that have a lot of information on the internet. The concerns are privacy. So anything you type in there, OpenAI owns, and they can use it to retrain their large language models. It could be inaccurate. It could be incomplete information. Depending on how you ask questions and what questions you ask, sometimes these large language models make up answers called hallucinations. So most famously would be like, if you say, what court case proved this, or what research study proved this, it might make up references. And then it's uncertain whether this is going to strengthen or hinder clinical relationships if you're asking this third-party technology for these answers. So we're doing a couple of different studies on ChatGPT and on large language models in general. I'm just going to talk about one thing that we're doing, which is saying, can we use retrieval augmented generation to make ChatGPT or whatever large language model we use to make it provide better, more accurate, more relevant responses? Because in general, rare diseases have less information on the internet, and it's probably going to have less information feeding into the large language model. So the simple way to explain retrieval augmented generation is first going over how this usually works. You have a user who has a question. They type the question in. It goes into the giant large language model algorithm, which leverages all of the internet data on the internet that it scraped, and then it gives you a response. Retrieval augmented generation, the way that this works is you create a data source of information that you trust, that you think is important to reference. And then you create an algorithm where if you ask your question, the first thing it does, this retriever, first thing it does is it takes the question you ask, what is Gorham-Stout disease? And it goes to your data source and it takes information from that data source and tags it to your question. And then your question plus all the relevant data goes into the large language model together. And then you can tell the large language model how much it needs to rely on the data you've tagged, whether it's allowed to also go to its other sources and its other broader resources to answer the question. And then you get an answer based on that. So that's RAG in a nutshell. We're not sure whether GPT 3.5, 4, or 4.0 would be better. So we started out with Gorham-Stout disease, and we asked 4 questions, which are like, what is Gorham-Stout? What are the treatments of Gorham-Stout? What are the medical therapies that are available? What are the known genetics? A couple of questions like that. And then we had 2 experts do blind reviews of the responses, and we did every response in triplicate. And what we found is that, number one, ChatGPT 4 kind of, and blue is the model alone, it does a good job. So, which is kind of annoying when you're trying to improve it. But what we found, so ChatGPT 4 is the optimal model, at least for these questions in this disease. The other thing, though, is that the RAG in each instance does improve the quality of the response. So that was a really important proof of principle first, that we could build this pathway and show that theoretically, or at least in a small way, improves things. Then really the next questions, and these are ongoing projects that we're still discussing or still studying. One is, ChatGPT is expensive. And when you start having your question tagged with a bunch of pieces of data, you get charged for every bit of data that goes in and out. And so if we want to make a scalable tool that we can put on LGDA's website and anybody can click on it, you better have a big budget for that if you're using ChatGPT, because if thousands of people use it, you might get a surprise bill. If you can use local large language models that are available, like at our academic institution, we have access to the coding for 7 different models that we can use that cost us nothing. So the question now is, can we use RAG on these models that at baseline perform much lower than ChatGPT? Can we use RAG to bring them up to about the same level? And then we have something we can disseminate for free. And then the second question is that we're exploring is, can we develop automated metrics for assessing the outcomes of these experiments? Really what we want to do with RAG is, rather than just saying, with RAG or without RAG, I'd love to say, what happens if you've got 100 articles and all of them are relevant? What if you have 100 articles and 500 irrelevant articles? Does that mess up the quality? Can you have automated updates where you just pull information in routinely or updating that and that repository of information? But each of those experiments, if we're waiting on humans to score them, you might have thousands of experiments you want to run, and that might be months and months. Whereas if you could come up with an automated metric for RAG, you might be able to run tens of thousands of experiments in a day. So that's the other thing that we're working on, and we have a graduate student that is very interested in that question. So now for the last part, we're going to briefly touch on the barriers to accessing expert care in our VAXESS program that we're developing. And so all of those other technologies are really communication focused. Now we're trying to figure out, how do we overcome some of these issues that we identified? Like there's challenges getting a diagnosis, there's challenges getting referred to the right place, there's challenges with information. So the VAXESS program is we're fortunate that we have a DoD award for this. And we are just now in the development phases of this. We're going to start participatory design in about a week or two with primary care doctors. Preceding this, we did what's called a needs assessment with primary care doctors to understand, when you see patients with rare vascular disorders, what is your approach? What type of resources would be helpful? And so all of the resources we're going to talk about on the next couple slides were informed by those interviews. But within VAXESS, the Vascular Anomalies program, there are three main components. And this is going to be a web-based set of resources. So there's a website. The vision is you go to the website and you click, do I want to go to primary care resources, patient and family resources, or the Vascular Anomaly Professionals Network? And for the primary care resources, the idea is that if you're a primary care clinician, these patients come to you in one of two ways. One way is you have somebody coming into your care and they have the name of a disease listed that you've never heard of, like they have caposiform lymphangiomatosis, and you've got 5 to 10 minutes to figure out how you're going to get ready for that visit and know what you need to do. The second way is they come in and you have no idea they're going to have anything until you walk in the room and they've got a big obvious malformation of some sort. So when we talk to primary care doctors, the things that they were really interested in having through this platform is educational materials at their level, designed for them and what they need, which is different than what specialists need. Educational materials that they can give to patients and caregivers. They also wanted the ability to ask asynchronous questions through a chat platform that's secure, and the ability to upload photographs. And then if needed, a smaller portion of them wanted the ability to talk one-on-one with a vascular anomalies expert. And then they wanted information on how to make referrals and where these multidisciplinary centers are. And they didn't just want the names of the centers, they wanted to know, how do you actually make a referral? Is it a phone number you call? Is it a form you fill out? Those types of things were really important to them. So we will start building these in collaboration with these families, or with these clinicians, in probably the next week or so. We're scheduling the first visit. For patient and family resources, this is mostly going to be a second tier where we really want to build this out, and we really want to engage with our patient advocacy groups to synergize. But the ideas that we have right now are listing where these multidisciplinary centers are across the country. Again, posting those educational materials. The communication tools we've talked about, like making a web-based version of VACOM, making that freely available through this website. The other idea is creating the opportunity for any patient or caregiver who says, I'm willing to be contacted about research studies now or in the future, that we could create a simple repository to have a cohort of patients we can go back to if there's new clinical trials, or if there's new communication studies, or if there's whatever else. And then the next thing we could consider is looking to some of those states that don't have multidisciplinary centers, and do we want to get a grant and pilot a telehealth intervention in those states through here? So this is all kind of second and third level, but lots of exciting potential here. Then the last thing is this Vascular Anomaly Professionals Network. And the idea is that ISFA is the International Society for the Study of Vascular Anomalies. It's wonderful in creating an international group that all can collaborate and all can work together. But within the states, our different disciplines are really siloed. So if you are, for example, we just did a study where we were looking at prescribing practices for the drug sirolimus. So this is a drug that's prescribed by pediatric hematology oncology, adult hematology oncology, vascular medicine, and dermatology. We were able to get great responses from our peds hemonc group. We really struggled to get in with dermatologists and vascular medicine because they're different silos or different cohorts. So can we create a center where we can all collaborate together. So the ideas of this network to create unique value for families, or for professionals is, can we have discussion boards, either a general discussion board or specific discussion boards for topic areas that are important or meaningful? Can we have regularly scheduled journal clubs that are a mix of scientific articles with case presentations? Can we send out research updates similar to what Mike sends out through LMI? Can we do that and kind of piggyback on that in a smaller version throughout the year? Can we build these opportunities for us to collaborate across disciplines? Once we get up and running, can we start having like a yearly retreat, whether it's virtual or in person, where we can really strengthen these ties and come up with new ways of advancing the care of patients? And then can we use this as a way of getting access to that registry we make of patients that are interested in being contacted? So these are all works in progress. We are launching this right now. It's going to take us about a year to build all of these components of VAXESS. And then the second year is going to be actually disseminating it and testing it. Our initial thoughts are that for the professionals network, that will make it open to researchers or clinicians, any level of expertise, if you demonstrate an interest in vascular anomalies. We don't want to turn people away who want to learn more. And we want to do whatever we can to strengthen this community and this network. So if you're on the call and you're interested, keep your eyes open and we'd love to have you. We're discussing whether this is something that is US based or North America based or this region. We're trying to sort through all of that. So open to ideas on that as well. So now just to conclude, what we've shown definitively is that patients and families really struggle to get the care they need. They really are carrying a lot of burdens, some of which we are aware of and some of which are hidden to us. We talked about 3 different ways that we can leverage technologies, hopefully to help with some of these issues and hopefully to mitigate harms of these issues. But there's new ideas that are going to be coming and there's new technologies that are going to be coming, whether we want them to or not. So I think the parting question and the reason I'm getting so invested in this field is, as clinicians, we have to decide what role we want to play. The technologies are going to come and we need to get engaged up front so we can figure out how to leverage them for good and strengthen relationships, strengthen the outcomes for these families, rather than waiting for them to become cemented into our practice and dictated to us about how we practice. And with that, I'm going to stop. I have so many people to thank, so many advocacy groups, funders, and collaborators. It's been an amazing ride with all of these wonderful people. And with that, I will stop and happy to engage in any further discussion.
Wonderful presentation. And for people that want to ask a question, you can either raise your hand or just unmute yourself and ask a question. And I'll kick off the discussion. I'm curious about how you go about advertising and disseminating these tools after you build them, because they're going to be amazing resources, but sometimes you don't know what you don't know. People don't know that this tool is out there. So how do you reach those people?
It's a really critical question, and I think that applies to each one of these tools. I'll talk about the VAXESS specifically because that's, I think, the biggest challenge. If we're trying to get information to primary care doctors who don't know what their patient has, how do you get that information to them? So we are leveraging the principles of what's called implementation science, and we're going to be leveraging our implementation science core. And the idea is, how do you leverage all pertinent points of information transfer to get the right information and tools to the right people at the right time? And how do you make sure that using that tool fits within people's normal workflow? Because the other thing is, even if you know a tool exists, if it's not easy to use or you don't perceive it as useful, you're not going to. So some initial ideas for that particular tool that we have are, one is leveraging the strong levels of self-advocacy of patients, working with patient advocacy groups where they can bring information to their primary care doctors. 2 is working with different primary care organizations across the country, presenting at different primary care conferences. And then 3 is thinking about where primary care doctors are going for resources right now, which is often UpToDate or Google. So how do we work with our IT division to figure out how do we game the system so that when you search for vascular anomalies stuff, we're at the top of the Google search? we're working with some of the editors at UpToDate to see if it's possible for us to become listed as one of the useful links. If they say patient has Gorham-Stout, and at the end of the article, it's going to have helpful resources, how do we get ourselves to be one of the URLs that people click on there? I think it's going to be a little bit easier with the professionals because we know who we're reaching out to. With the primary care, even if you're a primary care doctor and I told you about it right now, you might not see a patient for 3-4 years where it applies. And so it really is a focus on how do we get it just in time to you. So absolutely the right question. That's what we're hoping to study in the second year.
Sarah?
Bryan, that was a fabulous talk. I always love hearing everything about what you're doing, and it seems like it's going to be really impactful for the community. Have you looked into using DeepSeek, which is that new free large learning model?
Yeah, so when we talked about using the different local large language models, what that means is that the company who owns the model is willing to give you access to kind of how it works, and you can incorporate it in. So at most US institutions, you're not permitted to use the general DeepSeek where the information goes to China, but you are permitted to use it as a local basis. So actually one of the 7 local LLMs that we're using is DeepSeek. And so we're going to be experimenting with whether we can add RAG onto that.
Cool. Cool. Thanks.
Mm-hmm.
All right, and there was a comment from Dr. Aeli that it was an amazing webinar and just very excited to be collaborating with investigators in this area, and that he's happy to join this expert professionals on vascular anomalies. And yeah,
Thank you so
we're
much.
happy to have you as part of the research network.
That is such an important point for a couple of reasons. One, when we think about communication, first of all, if I make a great tool in the US and we translate the words to your area in the language that's spoken in your area, that doesn't mean it still works. It has to take into account the cultural needs and all of that. It has to take into account how you overcome the unique barriers there. So I love the idea of engaging and thinking of how we start to make some of these tools more international.
Was there a question? Someone has their hand up.
Yeah, hi. I'm Ofelia Rodriguez Nieves. Thank you so much, Dr. Sisk, for your presentation. I really appreciate that. Being a mother, somebody who passed away because of a complication for a vascular anomaly, but also I'm a medical oncologist and I'm working clinical research. So somehow I'm having the chance to see your presentation from different sides, from the parental side, the research, and the medical side as well. So I think that you had made such a good analysis on what we had to face, and mostly, and together with Dr. Ayala mentioned, I'm based in Argentina, okay? Where by the time he was diagnosed, there were no other cases reported in the country. So somehow what we face, and you mentioned the issues you might have to face within US, those areas where patients may have no access. So figure out what could be here, or many other geographic or other countries where there's nothing at all, and we will, patients and parents and even, physicians will need to reach out to colleagues everywhere to get some advice, to get some guidance. So in that way, I think that you had summarized this perfectly. We know that there should be somehow that at certain point could be spread out. And in that way, I really appreciate what LGDA is doing with all these webinars and the chance to spread out, an update or bring updates on this specific conditions. But there's so much to do, so much work to be done, and also from the clinical research side as well. So thank you again, and congrats for such an amazing presentation.
Thank you. And again, echoing how important it is that we think how we maximize the benefits of this work throughout the world, because there's even more challenges in other areas where there aren't experts like you mentioned. So thank you so much for bringing that up again.
Well, I would just like to thank Bryan again for giving a wonderful presentation, and thank you to all our attendees. And we look forward to seeing you all next month at our next seminar.
Thanks a lot, everyone.
Bye-bye.